I think it's time to start, and I'd like first to thank A-Boehringer Ingelheim for inviting me in this distinguished symposium. It's my pleasure as well to welcome our dear friend Leonardo Fabri. I think Leonardo came here many times to Egypt, and it's a pleasure having you with us, Professor Leonardo. As we say in Italian, buona arrivata. I hope it's bene arrivata. Professor Leonardo Fabri is a very well international authority in the field of respiratory medicine and asthma COPD. And Leonardo is a professor of respiratory medicine and director department of oncology, hematology and respiratory diseases, University of Modena, Reggio Emilia, Italy. Molto bene. So we invite Professor Leonardo to give his talk about COPD. The title of his presentation is I lost my way. The screen is not. The COPD management strategy for 2013. Are you up to date or not? Professor Leonardo.
Dear Tarek, dear colleagues, thank you very much for the privilege to be here with you. What I will do in the next 40 minutes or so is to share with you some idea about the update of COPD management in 2013. And these will be the topics that I will discuss, and I will leave you enough time for discussion at the end. So regarding the definition, there are a few things that I believe we should always keep in mind. First, that what we are talking about with chronic obstructive pulmonary disease is a chronic condition that develops slowly and doesn't go back, that is induced by exogenous agent, noxious agent, cigarette smoking basically all over the world, or most places in the world. So the only COPD we know is the one induced by smoking. Is characterized by airflow limitation, by obstruction, because the one again that we have studied is the one with airway obstruction. That is progressive, not in everybody, but is progressive, and is associated with a chronic inflammatory condition. More important, or equally importantly, is that in a proportion of patients, about 30%, this chronic disease that usually manifests with dyspnea and with cough and sputum sometimes is associated with flares, with exacerbations, with that in about 20–30% of the patients occur regularly. On the other side, is never alone. COPD is not an independent disease. It's a disease of the smoker and the elderly. And when you have these two conditions, you have not only the lung that is involved, but the lung is part of the body that has been exposed to smoking and that develops several concomitant diseases that we call comorbidities. Now, a few years ago, in the guidelines of COPD, we were used to show these slide to emphasize, thank you, to emphasize the increase in COPD. And we thought that it was part of the past, 65 to 98. Well, In fact, and it was not only increasing, but it was also largely underestimated. You know, these were the diagnosed, and this was actually the proportion of subjects that had the airflow limitation measured. However, even figures published a few months ago in the New England Journal of Medicine have shown that among most of the chronic diseases, particularly ischemic heart disease, is going down. In the years, between 1990 and 2010, in the last 20 years, while ischemic disease, deaths of ischemic disease are decreasing, the one for COPD are increasing. We are not doing well with COPD. COPD is still on the rise. Again, the only COPD we know is the COPD induced by smoking, as shown in this slide by Monica Guerri-Torres, that is a very good Italian actress. Now, for ages, we have, as pulmonologists, focused on the effect of smoking in the lung. And we have developed a few concepts that are good, but limited to the lung. Everybody who smokes gets inflammation. However, a subgroup of smokers develop an abnormal and amplified inflammation that cause the structural changes associated with COPD, bronchiolitis and emphysema. So everybody in the room who does not smoke, if he smokes a cigarette, gets inflamed. We all get inflamed acutely, but then inflammation resolves and no damage occurs. 10–15% of the group will develop this inflammation that first is amplified and modified, causes these structural abnormalities and doesn't go back, and more importantly, continues even if you stop smoking. So it's independent from smoking. Just to keep your mind, to keep in mind what we are talking about, this is a normal airway, epithelium, thin wall, nice parenchyma around. This is a plug of mucus. Airway wall is already increased, thickened. This is a big thickening, remodeling of the airway. You see this? With not only mucus, but also pus, inflammatory cells, but no contraction of the smooth muscle. This is another airways where the muscle has been contracting and folds the epithelium. All these abnormalities, 1, 2, and 3, may occur in patients with COPD. Airway. The other point is the lung. This is the structure of a frozen lung, normal, and this is the abnormal. You understand that when you have this Swiss cheese lung, it's difficult to return unless you do something. You either make transplantation or regeneration of the lung. But this is destruction, and that's the picture of the lung of a patient with COPD. And I think we were appropriate, we were right in focusing in the lung. Is our business. We are pulmonologists and we focus on the lung, and the smoke, when you smoke, the smoke goes to the lung, so probably the lung should be the most important organ to be damaged by smoking. That's not true. That is not simply true. People who smoke die mainly of myocardial infarction, cancer, cerebrovascular disease, and only on the fourth place for COPD. So smoking is not affecting only the lung, but is affecting, it goes through the lung, and it causes damage throughout the body. So you as pulmonologists, whenever you see a patient with COPD, with airflow limitation, you should think that not only the lung is involved, but also the other organs, the heart, the vessels, the liver, the bone, the muscle. So you should think about cancer, you should think about the systemic effect of smoking and these complex comorbidities induced by. It's not me telling this story. This is the epidemic of the 21st century. This is what we are going to face. With aging of the population, the main cause of disability and death are the non-communicable diseases, the chronic diseases, multiple chronic diseases. And these have to change, this is the real challenge of our century. We have to change our attitude toward diseases. We have to change our medical school. We have to change our health system to address this epidemic of chronic diseases. This has been reported in these elegant articles. It's not only in developed countries, but also in developing countries. And as you can see, they represent, with respect to injury and more importantly to perinatal and infection, they represent the largest cause of death in the population. The trend is that, as I mentioned, the cardiovascular diseases are decreasing. Most of the malignant diseases are remaining almost no different. By contrast, the respiratory diseases increase over time, you see, and this is the trend for the chronic diseases. So, in summary, for this first part, the lung COPD is only one component of the multiple chronic condition that affects these elderly people who smoke. The other point is the exacerbations. And exacerbation is simple to define clinically. What is it? An increase in dyspnea that requires treatment. Patient comes because he can't breathe and needs additional medication. But the reason for not breathing well may be complex. In any case, the exacerbation of COPD are important. Why? Because in these 30% who have exacerbation, they die more, they go more to the hospital, they consume more health resources. They actually are the major burden of this. So you have to keep in mind that these people that have this exacerbation, about 30%, maximum 30% of the whole COPD population, require special attention. Require special attention. Now, how can we predict? How can we identify? Very simple. The main way to identify those at risk is to ask them, did you have a previous exacerbation, one or more? Those who have two or more are the subject that you identify as frequent exacerbator and that you should target. Is this phenotype consistent? Yes. Those who have two or more exacerbation are likely to remain exacerbator. That's why. However, again, exacerbation of COPD are in fact exacerbation of respiratory symptoms in patients with COPD. What does that mean? That means that you say, you just describe what you see when you say that the patient came because of an exacerbation of COPD because he had increased dyspnea. Because what we all think is the patient was stable, he got a viral infection or bacterial, he got acute airway inflammation on top of chronic inflammation, and he got an exacerbation. That's simple. But, however, first, these patients, as I said, have multiple morbidities, both respiratory and non-respiratory. So they may have concomitant asthma or bronchiectasis or fibrosis. So any exacerbation of asthma, bronchiectasis or fibrosis may contribute to this exacerbation of symptoms. Or they may develop de novo pneumonia or pneumothorax. And they appear exactly like an exacerbation of COPD because they have increasing dyspnea. On the other side, they have cardiovascular. How many times have you seen a patient coming telling you that he developed dyspnea, and then you took the frequency and he was arrhythmic, he had atrial fibrillation. Atrial fibrillation by itself manifests itself with what? Increased dyspnea. Hypertension, left ventricular failure, thromboembolism. All these may be causes of an exacerbation. So it's important, but it's also complex. So pneumonia, thromboembolism, acute heart failure, acidosis, anemia should be considered as potential causes or co-causes of COPD exacerbation. So COPD, once again, even in the acute stage, has to be considered a component of the complex. And so you have to consider the other risk, particularly the thrombotic and thromboembolism risk, and in order to identify the exact nature of this exacerbation. So in conclusion, there is an evidence for frequent exacerbator. The inflammation may be the most important, infection and inflammation, but comorbidities also may exacerbate. And now, what about the diagnosis? Let's go to the chronic condition. As you probably have seen, in the last version of the GOLD guidelines, or GOLD document, strategy document, as it is called, there has been a revisitation, let's say, of the classification of severity. Instead of using only airflow limitation, the diagram I have used also symptoms and exacerbation, creating this sort of A, B, C, and D prototype with identify these four groups of patients. Well, the idea was that there was an increasing severity in direction of A, B, C, D. Let's see whether it's true. I mean, there has been the analysis of the existing data just published in the European. This is published, it's not in press. And different studies have been compared. Forget this one because it's an epidemiologic population study, so it provides different. But all the others show that the main phenotype are A and D. By contrast, C is very rare, and B is more frequent. So if we go back, you see, this is probably not very frequent, and compared to the other, and mainly B is between A and D. But more importantly, if we look at mortality at different time courses according to the studies, you see that in one study, A, B, C, D is actually proportional to the original classification. So the more you go, the more the risk of death is increasing. By contrast, in the ECLIPSE study, that is a patient population, you can see that B and C are almost overimposed. So they have very similar mortality. And obviously D is always the worst and A is always the less. Are these phenotype reproducible? Again, A and D are reproducible, the other less reproducible. So this is what we have available. Now, what is the present recommendation for treatment? This is the old algorithm that we are all familiar with. Very simple. You get reduced risk factor vaccination and use short-acting bronchodilator whenever you need it, for all stages. However, depending on the severity measured on spirometry, you start your treatment with only PRN short-acting, only long-acting plus inhaled steroid if there is a risk of exacerbation, and you use oxygen and supporting all other treatment in the more severe. Now, has it changed with the new classification in severity? Not very much. A is only PRN. I would say that B and C is only long-acting beta-2 agonist, but interestingly, the most severe, those with risk of exacerbation, have an alternative between the LAMA, not the LABA, the LAMA, long-acting antimuscarinic, and the combination therapy. And I will tell you why this alternative, even in the last. These are second choices, we don't discuss that. What is the aim of treatment recommended and what you do for living? I mean, we try to make the patient less symptomatic and have less exacerbations. That's the two main aim of treatment. Do current treatment achieve that? Well, anticholinergic, long-acting, tiotropium, is it more effective than the regular short-acting? Yes, in terms of maintaining improved lung function over time. Does it reduce symptoms? Yes, as reflected by the fact that patients take less rescue medication, for instance, salbutamol. Now, are the new long-acting beta-2 more effective? Well, indacaterol that has been introduced recently is effective, is more effective than regular short-acting, but is effective as tiotropium in improving lung function and clinical outcome. We'll discuss later the exacerbation. Are inhaled steroids effective? Well, there is a controversial because of the risk of pneumonia, but there is very little risk that in patients with very low lung function and high risk of exacerbation, inhaled steroids are effective. Is the combination of LABA and inhaled steroid effective? Well, this is one of the classical studies, placebo, the steroid, long-acting, and combination, clearly showing that the combination improves lung function better than the single agent and placebo, and also reduces the exacerbations. The same with the other combination for formoterol budesonide, obtaining the same effect on lung function, on symptoms, on rescue medication. How about exacerbations? Again, here is the recommendation. I underline these 2 points, LAMA versus combination. Now, does tiotropium reduce the exacerbation? Classic study, yes, indeed. It does reduce the exacerbation. Is it better or equal to salmeterol, that is the other frequent long-acting used? Is better. Clearly shown, the largest study ever done in COPD, the POET study, prevention of exacerbation of tiotropium, clearly showed that patients treated with tiotropium, and remind this figure because you will see a similar one later, is definitely better than salmeterol in reducing the exacerbations. Now, of course you will ask me, but what about indacaterol? Just came out. It is once a day. Well, The Invigorate study, published a few months ago by Mark de Kramer and colleagues, clearly show exactly the same results in one-year study comparing head-to-head indacaterol and tiotropium, like the previous study comparing tiotropium and salmeterol, and clearly show that they are similar in terms of improvement of lung function. But again, almost identical to the previous, the TO is more effective than the indacaterol in reducing exacerbation. So the conclusion of these studies are that in these patients, indacaterol provided clinically relevant improvement in lung function with comparable safety profile. However, tiotropium offered greater protection from exacerbation, and the present data consistent with the current recommendation to use LAMA, and particularly tiotropium versus LABA, and particularly indacaterol. Someone asked me before about the combination of a colleague, a young lady colleague asked me about the effect of combination. Here are the data. Veshika reported again in the August issue of the Lancet Respiratory Medicine the comparison of a LAMA versus another LAMA versus the combination of a LAMA glycopyrronium with indacaterol. And it shows that not in severe, not in moderate, but in mild exacerbation, there is a significant better effect of the combination. So we might have, because this was powered on lung function, we might have to make a comparison between combination bronchodilators and combination of bronchodilator and steroid. So the problem with the combination of bronchodilator is the concern about the cardiovascular. We discussed this morning in asthma, and I think is even more appropriate now in COPD. Many patients with COPD, about 30%, have cardiovascular condition, atrial fibrillation, ischemic heart disease, chronic heart failure, or combination of these. And in this patient, bronchodilator may have some problem. We don't know exactly. But you have to use bronchodilator only when you're sure that the symptoms actually are due or are reversible with bronchodilator. Cardiologists are just saying that it's time to conduct specific studies in patients with both cardiovascular and COPD, just to make sure that efficacy and safety are properly measured in the target population we are interested. In this respect, the concern, as you know, was not only for LABA, but also for LAMA, to the point that about 1 year ago, Richard Beasley and colleagues called for the withdrawal of tiotropium delivered with the Respimat because of the suspect increase in mortality, cardiovascular mortality. Well, the question was well taken, it was well based, it was well taken by the literature, by the scientific community, and more importantly by the company who designed a study of long-term study in a very large population to assess the safety of tiotropium delivered with the Respimat compared to tiotropium delivered with the Handihaler. And the data have been published on, actually in the New England in September. There was at the time were an abstract form, basically showing that there was no concern. There was no difference in efficacy, but no difference in mortality between the two forms of treatment. So no concern on mortality with tiotropium. What about the combination? Yes, the combination is indeed more effective compared to the single component combination of steroids and LABA. However, all the study conducted with the inhaled steroid have clearly shown that there is an increased risk of pneumonia in patients treated with steroids. You see, 84, 88. Now, I ask you to follow me in a simple exercise so you have the understanding of what is the size of the problem. Let's go back for a moment. 1.13 means that you have 1,130 exacerbation in 1 year in 1,000 patients with COPD. If you treat them with the combination, you go from here to here, you reduce about 300 exacerbation, all right? 1,000, 1,130 versus 850, 300,000 less. So you reduce by treating 1,000 patients, 300 exacerbation. What is the increased risk? The increased risk is from placebo, is about 33 pneumonia. Not fatal pneumonia, pneumonia that requires treatment in the hospital. So you are practicing pulmonologist. With this calculation, you reduce 300 severe exacerbation requiring antibiotic and steroids with the risk of about 30 pneumonia. It's a risk, it's consistent, but for a practicing clinician is, in my opinion, is not a major risk. By the way, there are also data, even if unfortunately retrospective, suggesting that in fact the increased mortality for COPD, the increased prevalence of pneumonia may be only with fluticasone. I don't think it's right, but there might be some difference in the different steroids in increasing the risk of steroids. But the bottom line is that when is needed, I think that the steroid should be given together with the long-acting to reduce exacerbation, with the understanding that you have some increase in risk of pneumonia. But going back to our algorithm, I would say that the first choice in this kind of patient is the LAMA alone. And only if the LAMA alone is proven to be effective and safe, if the LAMA alone is not sufficient, then you move to the combination or to the triple. Does it work, the triple? Well, according to a short study performed by Tobias Belte and colleague, there was some effect on exacerbation at 3 months when adding the formoterol budesonide to tiotropium. However, it was only a short-term study. By contrast, a 2-year study has not shown a significant effect of the triple over the individual component over time, as shown by Aaron and colleague in different studies and by Vishaveshika in other studies. Particularly the Aaron study has failed to show any difference on the primary outcome, that was the percentage of patients with exacerbation. Other tools, as you know, lately we have registered roflumilast. Roflumilast is a peculiar drug, is oral, is anti-inflammatory, has been shown to be effective only in a specific population with chronic bronchitis and frequent exacerbations. In this population, I think is appropriate. We are not making use of a good drug that obviously in a very small part of COPD patient is useful. And once you have taken care, I mean, the side effects are tolerable, are not so heavy, and I think that we, as a skillful expert clinician, should be able to use this drug and take advantage of this drug in reducing exacerbation. But having said that, with the tools that we have to cure or to treat the lung, the respiratory component, we actually don't do much. At the most, we reduce the risk of exacerbation of 30%. Going back to the issue of the comorbidities, I think that we have to keep in mind that exacerbation may have multiple causes, and particularly may be due also to other conditions. So, because the patient have concomitant chronic diseases that are treatable, I think we should always treat them properly. For instance, it has been shown, retrospectively unfortunately yet, but the use of angiotensin-converting enzyme, angiotensin receptor blockers, and statins and beta blockers reduce exacerbation, hospitalization, and mortality in patients with COPD. This is the data with the beta blockers. So that it should be used. We should identify and cure ischemic heart disease, chronic heart failure, arrhythmia, all the cardiovascular conditions, and treat them properly. There is one exception where we have to be very careful in using beta blockers in this patient. That is the patient with severe oxygen-dependent COPD. There you have to be careful. For some reason, these guys in Sweden have shown that the use of beta blockers is associated with increased death. What about vice versa? We just finished a study, large study in Europe, 3,200 patients with documented cardiovascular. We went into the cardiology clinics. They all had an ischemic. They had either a bypass or an angioplasty. And we measured spirometry. And we found that 30% had obstruction and 10% had restriction in their spirometry. So 40% of the patients had abnormal lung function. 90% didn't know about it, never measured lung function before. Now, is it important to detect COPD in patients with cardiovascular disease? Yes, it is. Why? September issue of CHEST, the STEMI registry. STEMI stands for ST elevation myocardial infarction. All people with infarction, about 3,000 people, followed for 3 years. Those who had concomitant, about 20% who had concomitant COPD, had an increase of up to 20% mortality compared to 15%. So they had a 50% increased mortality compared to the others. And they had an increase in the frequency of admission to the hospital. So not only we have to identify treat cardiovascular disease in people with COPD, but also COPD in people with cardiovascular diseases, because probably treating them, it improves the prognosis also of these cardiovascular patients. So the bottom line is that I hope I convince you that this algorithm is pretty good. Probably we don't need this, this category of patients that could be unified with the B and C, but the progression of sub-PRN, long-acting beta agonist, particularly long-acting anticholinergic first, and only second choice the LABA, and then only in the very severe with frequent exacerbation use the combination or triple, is a very simple and reliable algorithm of treatment. But don't forget comorbidities and treat them accordingly. These are the points I discussed, and I'm very glad to take any question now on. Thank you very much.
Thank you very much, Professor Leonardo. As usual, a beautiful and wonderful overview about the new COPD management and the new strategies in the protocol of management of COPD. And Hadrifan, you start. Ladies first. First question.
Thank you very much. blockers has an effect on beta 2, blocking effects. How can we use without fear of affecting beta receptors, beta 2 receptors?
All the studies that have looked at the safety and efficacy of beta blockers in patients also with COPD have shown no decrease in lung function, no adverse events, but only shown the positive effects on the cardiovascular component. The only study that have reported a negative balance is the one in patients with severe COPD that requires long-term oxygen therapy. But the recommendation is whenever you have a patient with COPD that has also a cardiovascular condition, particularly chronic heart failure, that requires beta blocker, give it, no problem. Give it, no problem. The cardiologist will still ask you, please measure lung function, tell me if they are obstructed, because if they are obstructed, we don't treat them, wrong. The message is, use them.
Thank you very much.
You're welcome.
Dr. Gamal, Professor Gamal.
Thank you very much for your excellent presentation. I ask about the assessment of COPD patient. The group C, there is a large question mark about the presence of high-risk patient and the low symptomatology. How we met patient with COPD with poor pulmonary function and frequent exacerbation, and at the same time they have low symptomatology.
At the same time have?
Low symptoms.
Low symptoms.
Less symptoms. The category C.
Category C.
He meant the category C that how come that you have frequent exacerbations with a high risk and you have at the same time lower symptoms, and it's category C.
That's a good point. That's why these patients don't exist. That's why we have the C, that's why we have the C group that was constructed on a theoretical basis, and I'm guilty because I was part of the game, but they are rare. They almost non-existent. You are absolutely right.
Let me put another question. If you have an MMRC less than 2,
yeah,
and a CAT above 10, so how come?
Yeah.
How would you put it?
Yeah, you have to take the highest of the two.
You take what? How?
MRC.
The highest.
MRC.
So if you have
2 is high, it's probably high. Probably we have to lower a little bit, but basically I don't know whether you do it in your practice here. We don't use very much this score you usually ask, how do you do, sir? That's the usual question, and how frequent is your cough, how frequent are your symptoms. So I think that exacerbation dominate the clinical picture.
That's right.
So if you have a patient with a severe exacerbation, particularly with the hospitalized exacerbation, I think you should be more aggressive, independently from the frequency or even symptoms. Why? Because there is evidence that those who have an exacerbation of COPD are life expectancy very poor on the short term. So overall, in answering more appropriately to your question, I think that even in the few patients where you have not many daily symptoms, but you have frequent exacerbation, and I agree, there are not very many, I think that we should be aggressive because those patients are probably at risk. Similarly, those who have frequent symptoms, who have a lot of symptoms, even if they don't tell you that they had a major exacerbation, even if they have no hospitalized exacerbation, should be treated aggressively. That's why I see that A, PRN, B and C, I would put them together and I would use either LAMA or the combination already. And in D, we probably use the triple.
Are you in the future, you'll cancel the C, or the newest guidelines, are you going to keep the C, or maybe you fuse C with a D or B and C?
Yeah, that's a big issue. Tarek, we still have big unknown. I mentioned before. Everything we discussed today has been proven in patients with COPD and smoking. All the studies. Now, we have about 30%, 20% of people who don't smoke. I mean, around the world, you may have pollution, you may have cooking, you may have, but in other parts of the world, we don't know what it is. So that's another form of COPD that we need to study. Second point is, how many times we, elderly, smoker, cough, sputum and dyspnea. Clinically, you visit rails, bronchi and rails. Clinical picture of COPD, right? You do spirometry and it's restrictive. Restrictive. It makes sense if you have chronic heart failure and it makes sense. Are these people COPD or not? In my opinion, they are COPD. But lung function doesn't fit with our definition. Any study conducted in these people? No. Or, same picture, elderly, 70s, smokers, cough, sputum, dyspnea, normal spirometry. Highly symptomatic. We don't know. You do a CT scan, you can see a lot of holes, a lot of emphysema. And no studies done there. So, my approach is simple for the time being. Until we have the studies, we have to go back to our clinical background, make our clinical diagnosis, treat them like they were COPD. If they respond, you continue. If they don't respond, you take it out. Nothing else you can do.
Other parameters, then if we went like volume may decrease after treatment. If you want maybe normal, but
oh yeah,
we change in other parameters like residual volume, the space, compliance, all these things.
Yeah, not a single study has shown an effect on the evolution of the disease. Not a single one. Laplift, Isolde, no one. So unfortunately, like in asthma, we are not good at curing this disease. We are good only at treating symptoms. So unfortunately, and even if it is appealing the concept that early treatment, in Gold Zero, the symptom, the normal lung function, it will be okay. We don't have evidence.
I think we'll have a couple of questions because just to mind you that Professor Leonardo Sabri has to be at the airport at 2 o'clock in 5 minutes. He has to leave, and we really appreciate your coming.
Thank you
For such a short visit.
Privilege to be with
please,
you.
a small question, a small answer.
The value of a statin getting more and more important right now. So it's not COPD alone, it is a chain of complication, as you mentioned, diabetes and cardiovascular and so on. So last April, the Canadian Society of Diabetology announced that every diabetic patient should receive a statin. Now I can announce from that room, every COPD should start with a statin in order to not develop, to push forward complications, as you mentioned. Thank you.
Yeah, he just mentioned that he was he trained with Attilio Maseri, so you got a good training. You're absolutely right, sir. And again, the concept is very simple. For COPD, the treatment that we have is purely symptomatic. For the comorbidities, if you treat properly diabetes, obesity, osteoporosis, chronic heart failure, ischemic heart disease, you prolong the life of the patient. So you should use all the treatment required in this patient. But in order to do that, you have to search the comorbidities, and most of the time they are not detected. Having said that, Thank you very much. I have to leave.
Thank you very much.
Tarek, you promised next time
Yes.
we have to visit Cairo together.
And we'll make a nice trip to your lovely place. You love the Sharm el-Sheikh. And please,
Thank you.
The future of this country will be good and it will be bright. So
Thank you very
please don't look to the TV too much and avoid the media which exaggerating facts. Grazie mille, Leonardo Fabio. Thank you so much.
Thank you very much.